Now I'm very pleased to introduce the last speaker of our afternoon session, that among other important commitments has a very special one, that is to be the chief editor of our journal, the European Respiratory Journal, Mark Humbert, that will talk us about vascular, lung and heart remodeling in pulmonary hypertension. Mark.
Thank you. Thank you very much, Marina, Professor Crimi, dear Leo. It's great to be here today. I was with you last year. I must say it was a very nice time, and this year is very nice too. So we feel home, as Pascal said this morning, and thanks very much for your friendship. So what I'm going to try to do is to discuss rapidly some important findings on vascular, lung and heart remodeling in pulmonary arterial hypertension. Many people think that pulmonary arterial hypertension is not for respiratory doctors. It's not true at all. And it is a real pulmonary disease, and the consequence is the right heart failure. But the disease really lies in the lung, and it's a true pulmonary disease, a pulmonary vascular disease. And we really have, as a community, to take care of these patients, because this is our duty, I think. So these are my disclosures. And I would like to start with a very simple definition. When you deal with pulmonary hypertension, you deal with a hemodynamic condition. It's defined by right heart catheterization. You may screen people with echo Doppler, but the definition is really invasive. You have to measure elevated pulmonary artery pressure. And the definition is a mean, not a systolic, a mean pulmonary artery pressure above 25 millimeters of mercury. You may know that the normal value is 14 and the standard deviation is 3. So when you have a patient with a mean pulmonary artery pressure above 25 millimeters of mercury, it's already quite advanced. And this morning and this afternoon, we listened to many colleagues stating that we establish respiratory disease diagnosis too late. And I can tell you that when a patient is diagnosed with PAH, usually they are extremely advanced with, on average, a mean PAP of 50. So we are really dealing with a condition for which we need to have more early diagnosis. And I will discuss that during my next lecture in the late afternoon. Then I think we have to focus a little bit more on pre-capillary pulmonary hypertension. So pre-capillary pulmonary hypertension means, in fact, that the condition is due to pre-capillary remodeling and vasoconstriction. And these pre-capillary pulmonary hypertensive patients do not have left heart disease. If you take 1,000 patients with pulmonary hypertension, 800 will have left heart disease, and they will have post-capillary pulmonary hypertension. And this is not a pulmonary vascular disease. This is a left heart disease with pulmonary hypertension due to elevation in post-capillary pressure. If you deal with pre-capillary pulmonary hypertension, you really deal with a pulmonary vascular condition, and that's really the focus of our interest right now. And you will see later also that we have new drugs, quite a lot of drugs, labeled and approved for pre-capillary pulmonary hypertension. We have patients with elevated mean PAP above 25 and a normal pulmonary wedge pressure, a pulmonary wedge pressure below 15 millimeters of mercury. And the consequences of this pulmonary vascular disease is right heart failure. Initially, the right heart will be stronger. It will have a thicker wall, and then it will quite rapidly fail with a dilatation, and there will be right heart failure. And these people will present with non-specific shortness of breath and limitation at exercise. They will maybe have chest pain, they will maybe have syncope, and they will be at high risk of right heart failure and death, sudden death often. This is what you see when you perform a right heart a CT of the chest in a patient with advanced pulmonary hypertension. You see that the right ventricle chambers are bigger than the left ventricular chambers, which is absolutely abnormal. When you have a pulmonary embolism, you know that this usually meets the criteria of severe pulmonary embolism, even if the patient is normotensive. And this is quite important to emphasize that in patients with advanced pulmonary hypertension, they usually have a very large right heart. It may compress the left chambers, and it may, in fact, lead to low cardiac output and secondary compression of the left ventricle. It's quite important also to mention that sometimes you have pericardial effusion, and it's usually due to elevation in right atrial pressure, which will lead to pericardial effusion. So the right heart remodeling is extremely important in pulmonary hypertension. If one day we have drugs which are able to improve the function of the right ventricular pump, it will be certainly very innovative, and we will be delighted to have such drugs. But right now, the only thing we do is to give diuretics to decrease the preload, and we have little and maybe no drugs acting on the right ventricle, at the exception, of course, of dobutamine, etc., but which cannot be used in the long run. This is quite important, but my focus today will be more on the lung. And I would like just to mention briefly the updated classification of pulmonary hypertension. So we have made a classification for clinicians, and basic scientists and translational scientists may use it for their own purposes, but this is made for clinicians, and clearly you see that each subgroup of pulmonary hypertension corresponds to a different pathomechanism and in fact a different management. For example, the most simple one is chronic thromboembolic pulmonary hypertension. The pulmonary vessels, the precapillary pulmonary vessels, are plugged by clots, and then these clots are transformed into fibrotic scars. And this is, in fact, a precapillary pulmonary hypertension which can be treated by endarterectomy. If you can remove the fibrotic tissue, you will cure the disease, which is very rare in pulmonary hypertension. Another very simple condition is, in fact, chronic respiratory failure with hypoxia. In those circumstances, you have very low oxygen tension in the blood, and you have vasoconstriction of the pulmonary arteries, and this may lead to chronic pulmonary hypertension. Pulmonary hypertension due to left heart disease, it's post-capillary, it's very common, and it is a different management and a different pathomechanism. And group 1 PH is extremely important because group 1 PH, it's a family of conditions which have in common endothelial cell dysfunction, smooth muscle cell proliferation, and in fact similar therapeutic approach based on what we will see later in the afternoon, PDE5 inhibitors, endothelin receptor antagonists, prostacyclin derivatives. But it's quite interesting to emphasize once again that all these conditions with different background are characterized by a broadly similar pathology. So to make the classification more pragmatic, these are the pulmonary vessels. You have the precapillary vessels, you have the postcapillary vessels, you have the capillaries themselves. PAH, group 1 PH, really consists in a remodeling of precapillary vessels, and pulmonary hypertension due to lung disease and or hypoxia also correspond to vasoconstriction of the precapillary vessels. So these two conditions, or these two subgroups of PH, are really focusing on precapillary vessels. Then you have pulmonary hypertension due to left heart disease. It's really post-capillary. And in between, you have, in fact, CTEPH, which is mostly precapillary, but with some post-capillary remodeling, as I will discuss briefly at the very end of my talk. So altogether, precapillary, it's our field, the field of the pneumologist, and it's mostly PAH, PH due to lung disease, and broadly CTEPH. Post-capillary, it's mostly left heart disease. So this is a normal vessel. A normal vessel is very soft, has a very thin wall, and is usually very compliant. When you increase your blood flow at exercise, you may have a cardiac output going from 5 liters per minute to 25 liters per minute without any elevation in pulmonary pressure. Why that? It's because these vessels are very soft, they are very compliant, and they allow higher flow without changing resistance. When you have pulmonary hypertension, you have progressive remodeling of the small pulmonary vessels. You see that initially, in pulmonary hypertension, you have neomuscularization of previously non-muscular capillary-like vessels. These vessels become more muscularized. You have also loss of precapillary arteries, so you have less room for increasing blood flow because of loss of precapillary arteries. You have more and more remodeling of the small pulmonary capillary arteries, which may be totally occluded and which may culminate into what we call plexiform lesions with a massive proliferation of endothelial cells, smooth muscle cells, and myofibroblasts. This is found in about half of patients with group 1 PH, especially idiopathic PH. Plexiform lesions are usually not found in postcapillary or pulmonary hypertension due to left heart disease. This is quite important to read. These are the three classic abnormal remodelings we find in group 1 PH. The most common one is medial hypertrophy. You see there is a quite large number of smooth muscle cells occluding progressively the pulmonary vessel lumen. You may see also that endothelial cells are proliferating. Usually you have only one layer of endothelial cells. Here you have multi-layer endothelial cells, which is absolutely abnormal. And you have also something which has been really overlooked for many years. This is fibrotic remodeling of the adventitia. These patients have fibrotic adventitia, and this explains in part why these vessels are so poorly compliant. So the vessels of patients with pulmonary arterial hypertension are remodeled, and the three layers are remodeled. Endothelial cell proliferation, smooth muscle cell proliferation in the media, endothelial cell proliferation in the intima, and adventitial fibrosis. I would like also to show you a very important lesion which is called onion-like remodeling, onion ring-like remodeling, which is in fact characterized by myofibroblast proliferation occluding the small pulmonary vessels. And this is a famous plexiform lesion. You see it's often found in bifurcation of pulmonary arteries. And this is a proliferation of endothelial cells, smooth muscle cells, and myofibroblast. These three lesions are really characterized by abnormal growth of the pulmonary vessel cell component. When you compare a normal vessel with a remodeled vessels, I think the most simple thing to summarize that is remodeling. You have proliferation of the small pulmonary vessels, and one day I think we will find maybe a preventative treatment or maybe a curative treatment, but it's not with the vasodilators that we will find the solution. The solution is certainly different from what we currently use. What we currently use is useful, but it doesn't cure the disease. It only prolongs survival, and we need to have a better approach and more targeted approach in the future. So this is the cartoon explaining how a group 1 PH occurs in most patients. Those patients have some kind of genetic predisposition. Many have BMPR2 mutations. This is a TGF-beta related gene, and some have other TGF-beta related gene mutation like ORC1 mutation. We have recently described other mutations with KCNK3, caveolin-1, and other, but genetic mutations or genetic predisposition is extremely likely in most group 1 PH, and combined to that you have a risk factor, and there is often a very strong inflammatory flavor. Autoimmunity, HIV infection, toxin exposure, drug exposure. So the combination of genetic background and inflammatory trigger is quite important, and this will lead to pulmonary vascular dysfunction characterized by endothelial cell dysfunction, smooth muscle cell dysfunction, inflammation, remodeling. And you progress from open vessels to totally restructured vessels. And it's quite important to understand because vasoconstriction is not that important. It might be important at the beginning of the disease, but certainly not at the very end stage of the disease when we in fact discover the condition. when we analyze growth factors in the small remodeled vessels, they are extremely present in the small pulmonary lesions of patients with PH. And this is an example. I could make many examples, but this is a famous one. PDGF is overexpressed in pulmonary hypertension, and you will see later in the afternoon that some colleagues have attempted to treat patients with imatinib, thinking that imatinib will block PDGF receptor tyrosine kinase. And I will show you some data. There were some interesting effects, but some unexpected side effects. So a few words on inflammation. You are mostly a specialist of COPD, asthma, and inflammation is prominent. In the field of pulmonary hypertension, inflammation was not believed to be prominent. However, when you read the classification of pulmonary hypertension, you find so many inflammatory diseases, such as scleroderma, such as lupus, such as portal hypertension, such as COPD, that it is very likely that inflammation per se may contribute to pulmonary hypertension. And in 1994, Rubin Tudor with Norbert Völker presented for the first time inflammation in remodeled vessels from patients with group 1 PAH. These are CD68 positive cells, so monocyte macrophages. And here, Frédéric Perrault, before going to Ghent, working with Bart Lambrecht, described it during his PhD thesis that dendritic cells were infiltrating plexiform lesions. So there are inflammatory cells in the lesions of patients with PAH, and these inflammatory cells may be simple bystanders, but they may also have an active contribution to the disease. Our colleagues from Gießen in Germany have systematically analyzed inflammation in pulmonary hypertension, and they have found that most of the inflammatory cells we usually find in inflammatory lesions are present in the lungs of patients with idiopathic PH, including CD3 positive T lymphocytes, including monocyte macrophages, CD68 positive, including mast cells, etc. And with Peter Dorfmüller in an editorial in the Blue Journal, we try to describe what are the main inflammatory abnormalities we usually find in patients with end-stage pulmonary hypertension at the time of lung transplantation. And you have some infiltrates with mononuclear cell predominance. You have some remodeling with smooth muscle cell predominance. You have some remodeling with myofibroblast predominance, and you have some remodeling with endothelial cell proliferation. So many things can occur during pulmonary hypertension, from abnormal remodeling to abnormal inflammatory response. And here are the real lesions we find, and there is no doubt that you have sometimes accumulation of mononuclear cells, that you have proliferation of smooth muscle cells, that you have myofibroblasts, and that you have endothelial cell proliferation, occluding the very small pulmonary vessels and thus increasing pulmonary pressure and pulmonary resistance. With Frédéric Perrault, during his postdoc with Bart Lambrecht in Ghent, we established a collaboration, and we described in great detail accumulation of organized tertiary lymphoid-like tissue around the remodeled pulmonary arteries, indicating that in fact during pulmonary arterial hypertension you have next to the vessel accumulation of lymph node-like inflammatory reaction, which may be in fact involved in local autoimmune or immune reactions. And this has been summarized in this very nice cartoon. You see what most people see usually, remodeled vessel, and what most people were only describing in the past, very large lymphatic vessels. And in fact, these very large lymphatic vessels are connected to tertiary lymphoid tissue. And within this tertiary lymphoid tissue, we currently analyze the local production of antibodies, and they are quite well structured reactions with dendritic cells and T lymphocytes interacting together, leading to local antibody response. In the classification of pulmonary hypertension, you have a small line here, which is called pulmonary veno-occlusive disease. It is a rather rare disease. You know, PAH is about 50 per million inhabitants, and here it's 1% of PAH. So it's rather rare, but it is important to take some time to describe what is pulmonary veno-occlusive disease, because it is not that uncommon, but usually it is not identified right on time. You see, usually in pulmonary arterial hypertension, the abnormalities are in the pre-capillary arterioles here. And in pulmonary veno-occlusive disease, the abnormalities, the remodeling lies in the pulmonary venous branches, in the small pulmonary venules. And this is quite difficult to diagnose by means of right-heart cath, because when you measure the pulmonary pressure, in fact, you do not find elevated pulmonary wedge pressure, because the occlusion is very, very distal in the pulmonary venules, and you in fact measure the right arterial pressure when you inflate the balloon in the small pulmonary artery branches. So what is really elevated, it's a true capillary pressure, but the wedge pressure is normal. So that's extremely tricky, and you need to be quite educated not to miss pulmonary veno-occlusive disease in the context of normal pulmonary wedge pressure. You have to know that in pulmonary veno-occlusive disease, the presentation is in fact precapillary, while the abnormality are in the very small venules. What I wanted to show you right now is how we identify the veins in the lungs. What we do, we inject ink in the pulmonary veins, and you see that the veins are very, very long. They lie in the septa of the lungs, and you see they are full of ink when you inject ink in the pulmonary veins, in the large pulmonary veins. And what you can see in pulmonary veno-occlusive disease is that these long septal veins are totally occluded by fibrotic tissue. So it's really interesting, because it's a subgroup of pulmonary vascular disease which predominates in the pulmonary veins. And the big problem is that if you give vasodilators, you will increase blood flow with a post-capillary occlusion, and you will develop pulmonary edema. Very simple, but quite tough for the patients. This is a remodeled vessel with a smooth alpha-actin, indicating that these vessels are also remodeled with smooth muscle cell proliferation. And this is another very interesting finding we have in pulmonary veno-occlusive lungs. This is patchy areas of capillary proliferation. In fact, pulmonary veno-occlusive disease is the same condition than pulmonary capillary hemangiomatosis, an extremely rare condition. And these two conditions are in fact the consequence of occlusion of the small pulmonary venules, which will lead to capillary proliferation in the area where the pulmonary veins are occluded. If you have a magnification, you see usually capillaries are monolayer of endothelial cells. Here you have multiple layers. And when you are a clinician, you know that PVOD present with hypoxia and low DLCO, only because they have in fact proliferation of the pulmonary capillary endothelial cells, which will indeed interfere with gas transfer. So quite interesting, quite pragmatic also. This remodeling of the lung is really important clinically in these people. Last comment on connective tissue disease. Most of us working on pulmonary hypertension have a lot of referral from internal medicine with patients with scleroderma. You know that about 10% of scleroderma patients will develop PH and they will die of it. And in fact, when we do transplant these people, what we find is that both the precapillary and postcapillary vessels are affected. And it may explain, at least in part, why these people poorly respond to pulmonary vasodilators and sometimes even develop pulmonary edema. Another important thing in scleroderma is that they often have diastolic left heart disease with diastolic left heart failure. This is what we observe at the time of lung transplantation, a small pulmonary venules, not totally, but markedly remodeled with fibrotic remodeling and perivenular infiltrates of inflammatory cells. The last thing I wanted to mention is chronic thromboembolic pulmonary hypertension. So because my topic was on remodeling, I could not resist to show you what we remove from the lungs of patients with chronic thromboembolic pulmonary hypertension. You have to bear in mind that the only condition you should never miss in the setting of pulmonary hypertension is CTEPH, because CTEPH is curable by surgery. If the patient has proximal clots, like this patient here, you see that if you remove this very fibrotic scar within the pulmonary arteries, you go back to normal vessel perfusion. A very important thing now is that we are able to do intravascular imaging. And this is what we find in the small pulmonary vessels of patients with CTEPH. What we can see here is a network of webs, slits, and branches within the pulmonary vessels. And what we try to develop right now is for non-surgical candidates to try to develop angioplasty of the small pulmonary arteries, to put a balloon in these vessels, to inflate it, to try to destroy these webs and branches. And this works. Our Japanese colleagues have demonstrated it. But right now, our recommendation is to establish a diagnosis of CTEPH, to assess operability by a CTEPH surgical and medical team. Operable patients should be operated because it is curable, but non-operable patients should be seen by experts who may propose targeted medical therapies, but also emerging therapies like pulmonary balloon angioplasty, which is brand new and which will come very quickly, I think, in our field. In the May issue of the ERJ, there will be an editorial and a paper by Japanese colleagues showing that angioplasty may lead to chronic decrease in pulmonary hypertension in non-surgical CTEPH. So my conclusion is that plexiform lesions and onion skin lesions are more or less typical of PAH group 1. Other arterial lesions are less specific. Medial hypertrophy is found in all kinds of pulmonary hypertension. Sorry. Proliferation recruitment of smooth muscle cells and myofibroblasts is a common denominator in different lesion types. Inflammation may be a driver or copilot of pulmonary hypertension, and one day maybe we will target this pathway in the treatment of PH. Pre-capillary and post-capillary involvement is important to define, not only for pleasure but also for practical management. And right heart failure is the end consequence of PH and is a major cause of death in chronic pre-capillary PH. If one day we can treat right heart failure, maybe we will not have to treat the pulmonary vessels, but right now we have to treat the pulmonary vessels. Thank you very much.
Thank you very much for your interesting presentation. 2 questions, only 2 questions, brief questions, please, Manel.
I was fascinated, obviously, by the inflammation. The lymphoid follicles that you find, have you studied if those B cells or T cells are monoclonal or oligoclonal? And that will kind of lead toward immune kind of thing, normality. And how, I think you said you are trying to identify the antibodies. How are you doing that? I mean...
Yeah, two aspects. First, the structure of the tertiary lymphoid nodules. They are very structured with dendritic cells, B cells, and T cells. And what Bart and Frédéric have showed is that it looks very much like what you find in COPD patients, for example. So it's structured, and what we do right now, we microdissect these lesions, and we try to analyze the V-beta rearrangement to see whether they are narrow or large. And we will have the data very, very soon, and I think we'll present the data at the ATS in a few weeks. We have sent it as a hot topic. And how do we find the autoantibodies? Right now, we do look for them in the bloodstream, of course. More than 50% of patients with pulmonary arterial hypertension have autoantibodies circulating in the bloodstreams, and there is some IgG deposition in the pulmonary vessel. So the flavor is very marked, but maybe it doesn't explain all pH, only a subgroup.
You don't look inside the lymphoid follicles.
What we do right now, we microdissect. We don't have the tools right now to identify the specificity of what we find, but we describe for the moment.
Mark, congratulations. Very nice lecture, as usual. I'm also fascinated by this story of lymphoid follicles. You've shown lymphoid follicles around pulmonary vessels. In COPD, it's very different. It's around the airways. It has also been found in the alveoli in pulmonary fibrosis. So what drives the development of these lymphoid follicles? Why are they in different places? And what are they there for? What's their role?
The real question is that we all analyze end-stage tissue, and maybe there are consequences of what's going on in the long run. However, I really think another point is that, the vessels and the bronchi go together, and maybe our tertiary lymphoid tissue are close to the bronchioles as well as close to the pulmonary arteries. That was a question from a reviewer when we published that in the Blue Journal. However, right now, I think the main driver, in my opinion, at least in some patients, is that there is some auto-antigen exposure, which are usually cryptic, but with the high pulmonary pressure, they are expressed. So it may not be an initial finding in most patients, but it may be a secondary response to the high pressure. However, in scleroderma and in lupus, especially in lupus, we know that anti-inflammatory agents can reverse pulmonary hypertension. So I think in lupus, at least, it may be an initial driver, but it's a complex story.